That's all the swelling that you see. In trauma, also cervical spine, right after airway, cervical spine, and arguably, and I'll say it again when I talk about trauma, cervical spine stabilization needs to be done before you manage the airway, because placement of endotracheal tubes and other advanced airways involve manipulation of the head and cervical spine in such a way that you can aggravate a cervical spine fracture and cause separation in the spine. So C-spine collars go on all trauma patients, whether they have burns or not, very early on, and even before you place an endotracheal tube. If you suspect head trauma in a burn patient, CT scan is going to be important as well. So when you have somebody with severe burns, the resuscitative phase primary survey is really the same for burn patients and trauma patients. Airway maintenance with cervical spine protection is then supporting breathing and ventilation as needed. Circulation with hemorrhage control means you're going to need a large bore catheter, at least one, maybe more, for giving volume to resuscitate a patient in shock. After this is assured, you can begin looking for neurologic deficit and other changes, and the patient will need to be completely undressed to discover all burns and injuries. The secondary survey is a detailed history and physical. The patient may or may not be able to give it. You may need to talk to their family about that. You got to get a CBC to see what's going on with your volume resuscitation, because again, even if a patient has not suffered frank hemorrhage, if you're giving large volumes of crystalloid solution to maintain blood pressure and hemodynamics as part of fluid resuscitation, you will dilute the blood so that the patient has a dilutional anemia, which will affect oxygen transport in a negative manner. And you may need to add red cells in order to get a good hemoglobin level and get good oxygen transport, even if the patient hasn't suffered obvious hemorrhage. You need a chem panel, including BUN and creatinine, because you need to know what's happening with the kidneys. Their response to all of this can be really negative, and you can see acute renal failure, pre-renal renal failure, as well as intrinsic renal failure as a result of inflammatory damage to the kidneys by all of the things that are going on with the generalized inflammatory response in the body's responding to shock. A UA to get a sense of whether the kidneys are functioning normally is helpful. Arterial blood gases have to include an additional measurement. They have to include carboxyhemoglobin, because a standard ABG will show carboxyhemoglobin in the same manner it shows hemoglobin. So it'll show very high saturation of hemoglobin. Unfortunately, some of that hemoglobin has carbon monoxide in the place of oxygen, which means oxygen transport is severely impaired. You can only know how impaired if you test specifically for the presence of carbon monoxide on hemoglobin rather than oxygen. So the ABGs have to have checked off an additional a panel on the lab test requisitions to assay for a carboxyhemoglobin. That is not done routinely with blood gases. EKG and chest x-ray can give you a sense of the EKG, how the heart might be responding to the presence of all of these evil humors of inflammation, which tend to depress cardiac function. And the chest x-ray gives you a sense of whether the patient is suffering pulmonary edema as a result of the burns. What do you think? Is this a true statement? Adult patients must maintain a urinary output of 0.5 ml per kilo per hour? And the answer to that is true. And you should probably be placing a Foley catheter in severely burned patients so that you can get a really accurate hourly output of urine, because you will need to give fluid initially, and then you may be able to reduce fluid resuscitation when the patient has the ordinary diuresis a day or two or three or four after the initial insult. So the hemodynamic support involves correcting fluid, electrolyte, and protein deficits. Albumin is the colloid substance used to correct protein imbalances. Any number of electrolyte solutions might be used to correct overall volume imbalance, although balanced electrolyte solutions like lactated ringers might be preferable to normal saline, which really only replaces sodium, has no other real electrolyte content to it. You have to replace continuing losses and maintain the fluid balance as best you can, but you don't really want excessive edema formation. But in the end, you've got to maintain an hourly urine output of 30 to 50 ml per hour for an average sized adult. Now, that means that you're going to have some kind of instruction from the physician to be running fluids at a particular rate and doing hourly urinary outputs. And urinary outputs that are inadequate are reportable. And in addition, if a large catheter has been placed into the central circulation, preload can be checked looking at CVP or with a Swan-Ganz catheter, pulmonary artery occluded pressures. All of these things might be part of the monitoring you're asked to do when you're caring for one of these patients to determine how much fluid you can give. It's a real balancing act and sometimes impossible to maintain blood pressure without a really significant and dangerous degree of edema formation. The recommendations for resuscitation are something like 2 to 4 ml of lactated ringer solution per kilo per percentage of body surface area burned. So you can work that out by an equation. Half of it is given in the first 8 hours, then a quarter of it is given over the next 8 hours, and a quarter of the next 8 hours after that. That would be the fluid resuscitation recommendations. But in a sense, that's a starting point. Because if you're having difficulty maintaining adequate blood pressure or urine output, you may need to give more than that. On the other hand, if your urinary output is adequate and blood pressure is adequate, and by adequate, I mean a systolic of no less than 90 and a mean pressure of around 65 or so millimeters of mercury pressure, then you might not have to give this whole volume, but that would be a good starting point volume. Now, the thing about inhalation injury is it increases mortality rates significantly. People who have suffered significant inhalation injury, 20% of them are going to die. Your goals are to improve oxygenation and not aggravate the interstitial edema, the pulmonary edema that will be occurring. And now, the pulmonary edema, again, is not necessarily, in fact, it's almost never the result of heart failure initially. It is simply the result of changes in capillary permeability as a result of thermal injury to the alveoli and the capillaries that are so closely adjacent to them. You can't allow the airway to become occluded by swelling. The burning can be so bad that bronchi and bronchioles can be swelled and nearly shut. So you're going to be giving humidified oxygen. You'll be keeping the patient's lungs kind of in an elevated position, Fowler's position, 30%, 45% elevation of the head of the bed to help with reduction in edema, having fluid accumulate more in the legs than in the thorax and abdomen. Racemic epinephrine, inhaled epinephrine, is the best way we know of to reduce swelling and bronchoconstriction that are the result of inflammatory injury of the smooth muscle of the bronchi. So that is the preferred inhalant in burn patients. Really bad upper airway obstruction, of course, leads to endotracheal intubation. And in the high Fowler's position, you as a nurse are going to be continuously encouraging coughing and deep breathing. You may be providing chest physiotherapy, which would be vibration and chest clapping to loosen secretions and inhaled particulate matter. You have to position the patient from side to side, even though you're keeping the head of the bed up. You may, in the case of patients who cannot or will not cough, or who have an endotracheal tube in place, which makes coughing less effective since it bypasses the epiglottis. You'll have to involve in frequent tracheal suctioning. And in patients who can cooperate, instrumental spirometry is really helpful. Ventilatory support is not unlikely. You wind up on a mechanical ventilator. Now, escharotomy is an interesting issue. If you have a circumferential burn, there you go, a burn around the entire circumference of an arm or leg, you get what is in essence compartment syndrome. The swelling entirely around the extremity increases pressure in the compartments beneath the skin that contain blood vessels, and the pressure in the compartment may exceed venous or even arterial pressure, compromising distal circulation, resulting in distal tissue death, loss of nerve function initially, and then loss of motor function, and finally loss of tissue. So, first of all, very important, get off rings, watches, or any other kind of jewelry that can wind up being a tourniquet as an extremity swells. Elevate injured extremities and attempt range of motion to promote good drainage of the lymph system, so swelling is minimized. You got to do hourly assessments distal to the burn of skin color, sensation, capillary refill, and peripheral pulses. And I'll say it now, and I'll probably say it again when we're talking about trauma. Loss of sensation distal to a swollen compartment is the earliest sign that you have significant compartment syndrome that needs to be treated. I know you're thinking, oh, well, loss of pulses. Loss of pulse is a relatively late sign. Your inability, you become numb from neural changes because the nerves are exquisitely sensitive to poor oxygen delivery. That's your early sign. But of course, capillary refill, peripheral pulses, you look at it all, especially if the patient can't talk to you. If they cannot communicate, how do you know they have lost sensation? It's a very difficult call to make, but you sure know when they've lost pulses, and things that are bad can always get worse. So you always assess every hour for a while. Escharotomy is done at the bedside. Basically, that's the physician slicing through the burned tissue in the skin and the swelling and permitting the swelling to expand without increasing pressure within the compartment. If escharotomy needs to be done, the patient's going to need narcotic pain relief prior to the procedure and probably frequently thereafter, as pain might be really significant. They will probably also need benzos to maintain their level of anxiety at a tolerable level. If you try to figure out what escharotomies are about, this person had really significant burns of their whole body. And they've got escharotomies pretty much everywhere. There's an escharotomy around the thorax and